My name is Lisa Zimmerman. I'm from the Rehabilitation Research and Training Institute in Albany, New York. Thank you for joining us for today's webinar, Practical Considerations Related to Pharmacology and Developmental Disabilities. These professional development webinars, which are presented in conjunction with RRTI and the Lewin Group for social workers, counselors, registered nurses, and other healthcare professionals, are supported through the Medicare-Medicaid Coordination Office, or MMCO, in the Centers for Medicare and Medicaid Services, or CMS, to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare-Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar series. To learn more about current efforts and resources, please visit Resources for Integrated Care at www.resourcesforintegratedcare.com for more details. Just a little housekeeping before we get started. Your microphones will be muted throughout the presentation. However, there will be a question and answer portion during this webinar. So if you do have a question, please click the Raise Hand feature on your control panel at the designated time, and you will be unmuted by the administrator. You can also type your questions into the chat window, and the administrator will ask the question out loud during that designated time. There will also be poll questions throughout this presentation. A window will appear with the questions, and you can submit your answers at that time. At the conclusion of the webinar, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete this evaluation survey in order to receive 3 contact hours each from the Michigan Social Work Continuing Education Collaborative, New Hampshire Nurses Association, National Board for Certified Counselors, and National Association of Social Workers. If you are unable to complete the survey at the end of the webinar, you will receive an email tomorrow with a link to complete the survey at that time if you have not already done so. So at this time, I'd like to introduce our instructor to you. Dr. Eileen Triggerboff is a clinical nurse specialist in a private psychotherapy practice in Western New York, and is the Director of Program Evaluation at the Buffalo Psychiatric Center in Buffalo, New York. Dr. Triggerboff has a doctorate in nursing science and is board certified in 4 areas, as well as being a national and international speaker and consultant on a wide variety of clinical, research, and professional topics. Dr. Triggerboff is author, co-author, and contributor to 14 books and dozens of journal articles, and serves on the editorial boards of several professional journals. Dr. Triggerboff is a partner in an independent research group and provides expert testimony and reports across the country. She is active in community service venues, including clinical settings and family support groups. She also serves as a computer systems and statistical consultant and belongs to numerous professional nursing organizations. We can begin.
Hey, it's too bad you can't see me. I'm, like ready to be seen. So we're going to talk about the practical considerations related to the pharmacology that's used of people who have developmental disabilities. And we're going to talk about the PowerPoint program that you have in front of you. The general outline of what we're going to cover today is the common presentations of developmental disabilities, which of course you probably know more about than I do because you deal with it every day. Assessment strategies with people who have DD, typical medications, the pharmacology options, because there are a lot of options and they are constantly changing, the behavioral changes and possible explanations that can accompany those behavioral changes, communication barriers with clients, communication tools for clients and caregivers, regardless of whether the caregiver is a family member or a staff member, and coping with resistance to assessment and resistance to treatment in general. So let's talk about the frequency of intellectual disabilities of all degrees in the United States. It ranges from 1.6 to 3% of the overall population in the United States. And it's a little different in different countries, as you can imagine, but generally that is the range. So you're going to be running into any level of intellectual disability about 1.5 to 3% of the time. You can have very mild intellectual disability, right up to very severe. The health problems that interfere when somebody has an intellectual disability, and for those of you who have not participated in a webinar before with me, we no longer refer to it as mental retardation. It's called intellectual disability in DSM-5, and so that's what I will refer to it here in the PowerPoints and in the presentations. So people who have ID frequently have these other healthcare issues that very much impact on their quality of life. The most common ones are epilepsy and immobility, either due from spasticity or because of another healthcare issue. There's significant oral motor incoordination, so the chewing and tongue movement and lips and jaw movements. Dysphagia, when we put DYS in front of something, it means bad, and phasia is swallowing, so they're not swallowing competently, so they're at risk for aspiration, and of course aspiration pneumonia, and those are significant quality of life issues. They usually eat very quickly, and it cooperates with their dysphagia to make them at a higher risk for choking. Respiratory diseases are one of the most prevalent causes of death among people who have profound intellectual disability. Mild cognitive impairment life expectancy is the same as the general population. It is not the case with certain major mental illnesses that might be layered on top of an intellectual disability, but the ID itself does not change the life expectancy at a mild level. So let's talk about comorbid psychiatric conditions. So the person has an intellectual disability, they have whatever physical disability is going on with them at the time, and they also have a psychiatric problem. In general, psychiatric problems are diagnosed much more frequently with the intellectual disability or the developmental disability population, and we'll talk about the specifics. Schizophrenia may have a prevalence of 3%. It's 1 to 1.5% worldwide, and it has been at that pace for at least 2,500 years from what we can determine from the writings of people over the centuries. It wasn't, of course, always called schizophrenia. It was called all sorts of imaginative features, but the descriptions of the symptoms remain the same, which is kind of amazing to us. The clinicians would have this idea that, especially in the 60s and 70s with the advent of a lot of recreational drug use, that we thought that there would be more schizophrenia as a result. But that didn't happen. The rate of schizophrenia remained the same, about 1 to 1.5%. But you have somebody with an intellectual disability or any kind of developmental disability, and the prevalence is twice as high. Bipolar illness is 2 to 3 times as prevalent in people who have any level of cognitive impairment than it is in the general population. And bipolar illness is something that people might not be aware of right away, and so they might not treat right away. And big problems with any major mental illness that's not treated competently as soon as the symptoms are detected. So we'll talk about that a little later. Attention deficit hyperactivity disorder. Technically, it's attention deficit disorder with or without hyperactivity, but the layman's abbreviation has always been ADHD. It's diagnosed in children in the general population 8 to 15% of the time, and even that's considered an overestimation, especially with the research that we conducted for DSM-5. But in people who have any level of intellectual disability, it's 17 to 52%. So we're talking almost half of people who have an intellectual disability may also have ADHD. Self-injurious behaviors require treatment in 3 to 15%, particularly in the severe range of intellectual disability. Major depression, autistic spectrum disorders, obsessive-compulsive disorder, not obsessive-compulsive personality disorder, but the obsessive-compulsive disorder as a major mental illness. Any anxiety disorder, obsessive-compulsive disorder, of course, but generalized anxiety disorder, some phobic conditions, post-traumatic stress disorder, acute anxiety reactions, conduct disorder, tic disorders, and other stereotypic behaviors, much more common in this population. So in general, what this slide is saying is we have a lot of information about people with intellectual disabilities and a psychiatric condition occurring at the same time. And what do we do about that? And that's kind of what we're going to talk about today. Emotional behaviors in general, and emotional behavioral problems in general, are 5 times the rate of emotional or behavioral problems. Intellectual disability is compounded by epilepsy. When it's compounded by epilepsy, which is extremely common, can increase the risk of a psychiatric problem to over 50%. So an intellectual disability with epilepsy, that co-occurring disorder, that little set, can rise above any of the other risks for a psychiatric problem that would previously exist or exist without epilepsy. Occult visual and occult auditory deficits occur in about half of people who have an intellectual disability. Sexually transmitted diseases, hepatitis B, and Helicobacter pylori infection, H. pylori, are increased significantly in people who have these problems. 1 in 5 people who have an intellectual disability also has cerebral palsy. 20%, as many as 20% also have seizures. We have a remarkable level of gastrointestinal complications. Feeding dysfunction, hearkening back to what I said before about dysphagia, where they're not able to move their tongue around competently in their mouth. They have some motor problems, and they have some dysphagia, swallowing problems as well. Excess drooling, which is also called sialorrhea. Reflux esophagitis, where the acid from the stomach refluxes, it shoots from the stomach into the esophagus, usually because the sphincter at the top of the stomach and at the bottom of the esophagus, right there at that juncture, happens to be on the level of the heart, so they call it the cardiac sphincter. Sometimes that can be kind of floppy and it doesn't have a nice seal to it, and so the acid that's supposed to stay in the stomach, because nothing outside of the stomach really wants to be exposed to acid, will be refluxed up into the esophagus, and it's acid, so it burns and it hurts and it creates an inflammation. So you get what's called reflux esophagitis. You get this infectious, it's not really caused by a colonized bacteria or virus, but it's an irritation and an inflammation from all of that acid. And of course constipation, which would exist normally with somebody who has an intellectual disability because of the way their GI systems are plumbed. But you add a lot of the medications that we have to give for their comorbid conditions, and it increases the risk of constipation. Genitourinary complications are pretty common. Urinary incontinence and poor menstrual hygiene for females, very difficult to manage. Profound social morbidity, they're not going to be able to work to the level that somebody who doesn't have these problems would be able to earn. There's a pretty serious dependence on social services. They have impaired long-term relationships because they don't have, in addition to intellectual disability, they all have an emotional, intellectual lagging. So they're not going to be able to figure out some of the very complex things that go into a human relationship, like political considerations, or telling a white lie, or being very considerate of somebody and not mentioning something that would be embarrassing to the individual, or they wouldn't be able to correct even if you did mention it. So they're not very good at differentiating between constructive criticism and just making a comment that the person can never really address. Like saying to somebody, boy, you're really short. Now, that's not constructive because the person can't do anything about that, and it can impair their abilities to have long-term relationships with people who are sensitive to those kinds of communications. And then there's some emotional suffering because people might not understand, or they don't feel understood by others, and either one of those situations is very uncomfortable. So the psychopathology that can exist with people who have intellectual disabilities and developmental disabilities is certainly aggression. The aggression can come from feeling put at a disadvantage or not getting what they want or having a delay in the gratification or just not understanding what's going on around them. They get confused and they might act out. Some of that aggression can be turned inward, so the person is self-injurious with their behaviors. They're cutting, they're burning, they're ingesting, they're pulling their hair, trichotillomania, which is more of an anxiety disorder, but it is self-injurious. There can be a defiance to how the person is interacting with other people. Inattention, they're not willing to spend what intellectual currency they have at hand to whatever you're presenting them. So they don't want to pay attention, or they're not able to pay attention. And that's not counting the people who have attention deficit disorder with or without hyperactivity. Some people can have hyperactivity all by itself. Anxiety disorders, depression, pretty common. Sleep disturbances can also be as a result of trauma, as a result of misunderstandings and communication problems, but it also can be because they're just uncomfortable and not able to get to sleep, or it could be a symptom of a psychiatric situation that's going on. Stereotypic behaviors, movements, hand movements, head movements, leg movements, facial grimacing. But before psychopathology can be identified in very young ones, infants and toddlers with intellectual disabilities are much more likely to have difficult temperaments. So before we've even diagnosed somebody as having ID, we're looking at a child who is very difficult to soothe, not getting along with situations, not cuddling, not resting. So their temperaments in general are giving us cues that this person, as they develop, might have some problems. It's not necessarily always the case, but it is something to pay attention to. They might be non-compliant or non-adherent with what's going on, like simple rules. They might be hyperactive. They might have disordered sleep. And colic is frequently the explanation for a lot of the previous mentioned symptoms. But colic can also indicate that there are the gastrointestinal plumbing problems that can happen with people who have intellectual disabilities. There are poor social skills and delays in play skills, where they're not playing to the level of their peers, or the parents have other children and they're hearkening back to what those children were doing at that age, and they're saying that, they're not doing the same thing. So what kind of other clinical observations can we make? So I just want to spend a couple minutes talking about how there's an overlap between developmental disabilities and other psychiatric disorders. And this is just a simple way of paying attention to the various developmental disabilities like Asperger's and autism, mental retardation, or intellectual disability, and other psychiatric disabilities which are common in this population: depression, schizophrenia. Depression is fairly common with everybody. 1 out of 4 women and 1 out of 6 men in the general population will have a depressive episode at some point in their lives. That's a lot of people. Schizophrenia is higher level for people who have intellectual disabilities, bipolar disorder, post-traumatic stress disorder, obsessive-compulsive disorder, and personality disorders. The overlap is withdrawal from social situations, social incompetence in general, and notice that these overlapping symptoms can happen with the developmental disability and also with a psychiatric disability. When you have both at once, you're going to have to pull the thread of where is this symptom coming from. Is the social incompetence coming from autism? Is the person not able to make eye contact or not able to acknowledge that somebody else is in the room and that they have the right to have feelings and expressions? Or is it coming from depression where they really don't care? They realize that someone else is in the room and it doesn't make a difference to them. Pessimism. Pessimism is a symptom of a psychiatric disability when it's new, when it is not a regular part of their personality. If people are pessimistic all the time and that's just part of how they live in the world, that is not a psychiatric symptom. But if somebody who is appropriately optimistic or appropriately even neutral about expectations about themselves and about the world and about the future, all of a sudden becomes pessimistic, that's a symptom of depression. Irritability, also, if the person is normally irritable, that's just who they are, then it's not a symptom of psychiatric problem at all. But if all of a sudden they're irritable, and it's not lasting a day or two, it's lasting for day after day after day, like 2 weeks, 3 weeks of this irritability that's not typical for them, then we're looking at depressive symptoms or the depressive aspect of bipolar disorder. Helplessness, if that's normally part of who they are, unlikely. It's not a typical personality characteristic that you'd be feeling helpless about your situation. So that's what's going to make us really pay attention to a psychiatric problem. Arousal, I'm talking not necessarily sexual arousal, although that could be in there. It's neurological arousal. That could be part of a psychiatric disability, especially bipolar disorder and the manic swing, or it could be part of an Asperger's or even an intellectual disability. And acting out behavior can come from just feeling uncomfortable or being in situations that don't suit you. So let's talk about treatment. There's no treatment available specifically for cognitive deficiencies. There's no medication I can give you to make a cognitive piece go away. That doesn't happen. And something important to pay attention to, we're going to cover that when we do the poll question, that there is no pharmacological treatment specifically that should have been identified. So pharmacologic enhancement of cognition, it's certainly an area of interest, and there's some very good information, very good research going on about that. But right now there is no specific compound that I can give anybody and that'll address their intellectual difficulties. So when you are treating somebody who has an intellectual disability, you want to have a complex habilitation plan. It's not necessarily rehabilitation because they haven't learned how to live in this particular way. So it's called habilitation because they're going through it for the first time. There's special educators, people who have special skills in this regard, and they can help impart these skills to others. Language therapists, of course, behaviorists, occupational therapists, community services that provide social support and respite care for families when the person is living with their family. For medications, there are specific compounds that target the psychiatric disease as well as the behavioral disturbance. Vitamin and mineral therapies are very popular, but whether they work or not has not been established by any cogent form of research. As a matter of fact, a lot of the research that has been done on vitamin and mineral and some of the alternative complementaries have been negative in their outcome. But they're very popular, and we know that for the most part they can't be very damaging. So if nothing else happens, you will just be spending money for something that doesn't work. Antioxidant supplements with people who have Down syndrome it's an interesting theoretical process, but every single piece of research that I've read on this has not been a rigorous piece of research. So that has not been very helpful. CNS stimulants like methylphenidate and dextroamphetamine, they appear to enhance dopamine and norepinephrine activity in the central nervous system, and it's the most common class of drugs prescribed with as many as 50% of people who have ADHD or ADD. So they're very common medications. And in general, why we're talking about medications is that psychopharmacology is necessary to treat a lot of the symptoms that are going on. We cannot treat the cognitive deficits with psychopharmacology, but we need to understand a little bit more about the practical application of pharmacology with this particular population. And that's going to be our general focus today. We want to be able to recognize what are the likely treatment options for a certain set of problems. people have problem A, problem B, and problem C. What are we going to do about that? What are we going to give that person? We don't want to give them so many medications that they start to overlap and become very complex, but sometimes we need to use different pathways to get to the same resolution to a problem. We need to be able to understand the pharmacology's major purpose, their main effect, and also what are the side effects. So if I'm giving somebody an anti-epileptic drug, an AED, because they have a seizure disorder, but also they have bipolar illness, and they need to have their mood stabilized, some of the anti-epileptic drugs will mood stabilize, such as Tegretol, or Depakote, or Lamictal, or Topamax. So they'll do both. So I'm going to look for the main effect, which is anti-epileptic treatment and mood stabilization. But the side effects I'm also going to look at. Some of these medications have sedating side effects. What if the person is really sedated all the time from other medications they're taking, or simply because of how they represent their particular illnesses? I'm not going to want to make that worse with a sedating side effect. But if the person is having a lot of trouble sleeping for one reason or another, the sedating side effect might help them to get more rest. So you're going to look at the main effect of the medication, and you're going to look at the side effect and see if that can be of some use, or at least a minimal problem. So why you might want to have a psychiatric medication added to all of the other medications that somebody is taking? Well, it can help minimize depressive symptoms. So you want to be able to have somebody who has depressive symptoms be treated. You don't want psychiatric symptoms of any kind to go untreated, because that will just entrench the psychiatric symptomatology, and it'll make it very unlikely that you're easily going to be able to treat it in the future. It helps to clarify thinking, and that thinking can be clarified because the person is very agitated, or they might even be psychotic, or they have depressive or manic symptoms that are interfering with their clear thinking, and psychiatric medications can help with that. Anxiety can be very obstructive to people learning or enjoying their lives, and so medications can certainly help reduce the anxiety at high levels. I don't really like to give medication for anxiety at low levels. That's actually instructive and motivating. If you're a little nervous, a little anxious about something, you're going to want to do something about that instead of just taking a pill. But some people will not be able to change their behavior. They won't be able to learn new cognitive or behavioral pathways to follow, in which case you're left with the pharmacology option. Medication can help the client have better control over impulses. Sometimes the neurological wiring makes the person much more impulsive than ideal, and the medication can help control that. It might just in general make the client feel better. Recipients have difficulty feeling different sometimes. They feel odd, they feel sad, they feel out of sorts, and they don't really know why. And sometimes medication can help steer them in that direction. And it can help keep functioning from slipping away. Somebody has worked very hard at trying to learn a new function or to get it fine-tuned. You don't want to have that disappear. You want to have that person hang on to those successes and those skills. So these are the symptoms that we would medicate: inattention, excitability, if someone is way too excited and overwrought about a situation. They're having trouble focusing, if they're aggressive, sleep problems, depression, psychosis, disorganized thinking. These are the kinds of things that we need to medicate. There are behavioral problems that accompany all symptoms, and hallucinations, delusions, disorganization, depression, mood variation, all of these things will affect how the person will be active in their life, how their interactions will proceed, how they're sleeping, how they're eating. In general, we want to assess for symptoms of major mental illness. We want to be able to pick up on those features as soon as possible. It's extremely important to get there as fast as you possibly can so that you can address the symptoms before they become well entrenched neurologically. And over the years, we've learned from a number of very reliable studies that the medications that we give for these specific disorders, schizophrenia, depression, bipolar disorder, and anxiety disorders, a variety of anxiety disorders, that when it has been determined that medication is needed, and with schizophrenia that's pretty much all the time, with depression it can vary, but bipolar disorder, it's the vast majority of people who have bipolar disorder. I think it's 99.9% of people with bipolar disorder must be medicated. And then anxiety is another issue where we can make a clinical determination on whether medication is necessary. But let's just say, for argument's sake, that all of these diagnoses need medication. What the research has shown over the past 25 years is that medication, psychiatric medications, have a neuroprotective quality to them. They protect the brain from degradation from these major mental illnesses. And if you need the medication and you're not taking it, then the disease will continue, and it will establish neural pathways that are going to make it much more difficult for people to function and for them to have a better quality of life. So you want to always be able to assess for these symptoms. Side effects is the reason so many people don't like to take their medications as prescribed. There are some benefits, but there are certainly risks to taking a medication that has side effects. I just wanted to mention about the side effects that happen particularly with psychiatric medications. There's a neurological process in our brain that's actually shaped like a pyramid, and it's called, imaginatively enough, the pyramidal system, because it's shaped like a pyramid. And then just outside of that pyramidal system is the extrapyramidal system. It's just outside. And that's where the side effects occur from psychiatric medications. They're called extrapyramidal side effects, EPS. Sometimes people say EPS, which is not entirely neurologically accurate, but I'll probably like a slide. But I will say EPS. And these are the major extrapyramidal side effect categories. Dystonia, DYS in front of something means bad, and tone is tone, so it's bad tone. It's basically a muscle spasm, and it hurts a lot. And sometimes people can have dystonic reactions that are very sustained. So that's difficult, and there are problems with that kind of side effect. And actually, and I'm not sure if I go into this in great detail. Let me just check myself here. Otherwise, I'll do it right now. I don't. Okay, I'll do it now. When somebody has a dystonic reaction from a psychiatric medication, it happens in particular muscle groups. Like if you're a runner, then sometimes you can get a Charlie horse, which is a muscle spasm in your leg. But with people who are taking psychiatric medications, a dystonic reaction can happen in the eyes, and it's a certain kind of muscle in the eye. The eye has dozens of muscles, tiny but very strong muscles that monitor its movement. And a dystonic reaction in the eyes is called an oculogyric crisis. Oculo meaning eye, and gyric means the gyroscopic function of the eye. So the eye can go from side to side fine, no problem. But once the person looks up, their eye goes into spasm, and the person cannot bring their eyes down to level again, and they can't look down. So they can't look straight out, and they can't look down. So their eyes are stuck in the up position, which is very frightening on top of being painful because it's a muscle spasm. So that's one dystonic reaction. Another is with the muscle that goes from, if you could see me, you could see, I would point to it, but it's the muscle that goes from behind the ear. There's a bone that hangs down behind your ear, a little tender spot there. That is the insertion of a muscle that goes from that area all the way down to the top of your shoulder. And when that muscle goes into spasm, as any muscle that goes into spasm does, the muscle fibers bunch up, they clump up, and they shorten. They are not long and lustrous and smooth and mobile. They're clumped up and tense, and they're locked into a ball. And if you lock up and shorten all those muscle fibers, you're going to notice that the person's shoulder is approaching their ear because it's in spasm, and that's called torticollis because it looks like a tortoise pulling its head into its collar. And if it happens on both sides of the neck, it very much looks like a tortoise pulling its neck down. You just raise your shoulders up to your ears. But sometimes it just happens on one side, and so the person's head will be tipped to one side. And then there's a third major area of dystonic reaction. There's a very wide, large, and powerful muscle on your back called the trapezius muscle, shaped like a kite. And when that goes into spasm, because the muscle fibers are shortening, the person is bent over backwards. And it can be so bad that the person can fall backwards because they're being pulled backwards by their strong back muscles. So that's a dystonic story. Akathisia, it is a restlessness under the skin. The person does not feel like they can sit still. They might be sitting still, but they don't feel like they can sit still. So they'll be moving, they might be dancing, they might be bopping and readjusting themselves and pacing, all sorts of different ways of representing akathisia. Very uncomfortable. And it can happen from an antipsychotic as well as an antidepressant medication, some mood stabilizing medication. Then there's something called drug-induced Parkinsonism, which is, it looks a lot like naturally occurring Parkinson's disease, and it has all of the same features to it, except it's a side effect of the medication. So some of the main features of Parkinsonism is that the person has all of the muscles in their body, inside and out, slowed down. So they don't walk very fast, and they don't blink very fast, and they don't reach for things very quickly. Everything is slowed down like it's in molasses. They also are tipped forward a little bit because they tend to walk on their toes. So the ball of their feet and their toes, their heel does not strike the ground. So they're tipped forward. Another not so nice feature of this is just by gravity. If you're tipped forward and your muscles don't react very quickly, you can't move very quickly, and someone bumps into you, you're going to fall. And you're going to fall forward because you're already tipped forward, and you will not be able to put your arms out to stop yourself because you can't move that quickly. So you're going to have some injuries. You're going to have black eyes, you're going to have nose problems, you're going to have chins that are cut, plus also because the muscles in the throat are not firing as fast as the skeletal muscles, and the person's tipped forward anyways, they're going to drool. Can't swallow their saliva fast enough, as fast as it's being produced. So while somebody who's in their 80s might have naturally occurring Parkinsonism, and it's just one of the unfortunate aspects of aging, drug-induced Parkinsonism means that all this is happening with a 24-year-old guy, and that's not normal, and they're not going to like it. And they might refuse to take some of their medication because of the side effect of it. Then there's tardive dyskinesia. Tardive dyskinesia is the root of it, the description of the title. Tardive means late arriving or slow, as in you're tardy, you are late for something. Dys is bad, and kinesia is movement. So it's a late arriving bad movement. And it's not under the person's control, although they can distract from it, but there's ways to detect it very early, and that's what you need to do. You need to detect it as soon as possible. It can occur as at least 3 months after you start treatment with a medication. It's usually the older antipsychotics, not so much the newer ones, but much more like Haldol, Thorazine, Stelazine. Those kinds of medications have a tough reputation for tardive dyskinesia, or abbreviated TD. It's frequently associated with irreversible abnormal movements, and by frequent, I mean this is a neurological syndrome that can happen in between 6 and 10% of people taking the medication, but it can be permanent even after they stop taking the medication in about 10% of those people. So that's pretty frightening to have that kind of a problem. Then there's anticholinergic side effects. Just when you hear anticholinergic, just think dry. Every single thing in your body can dry out, like your mouth, your eyes, which can lead to blurry vision, because it's not just the surface of your eyes that are going to have some dryness to them, but also the vitreous, the fluid inside your eye can be dried out a little bit, and it makes it harder to focus. And you can become more constipated because your gastrointestinal system is dried out. Your genitourinary system, your GI tract, is dried out a little bit, so you might have some trouble urinating. So there's all sorts of problems from being dried out. You can get a headache from being dried out. You can be nauseous from being dried out, and that needs to be taken into account. Some additional side effects of psychiatric medications is neuroleptic malignant syndrome, NMS. Not very common, but it used to be 30, 40 years ago that you could go your whole career and never see a case of it. Now it's diagnosed much more quickly, and we don't know why it's happening more often, whether our diagnostics are so much better or people are more sensitive, don't know. But we do know that it's not the absolutely horrible, dangerous thing that it used to be 20, 30 years ago. If somebody got neuroleptic malignant syndrome, which usually means your temperature goes up, your blood pressure goes up, you become very stiff and rigid, and you start to lose consciousness. That, with your temperature rising, can be a very dangerous situation. You need to be medically treated for this problem. But it used to be that if you were on, let's say, for example, you were taking Haldol and you got neuroleptic malignant syndrome, years ago, before a lot of research was done on this, we thought, all right, this person can't take Haldol. And in explaining it to caregivers or family members or even the recipient, we would say, you can't take Haldol. It's like you're allergic to it. It's a bad thing. So then people would say things like, I'm allergic to Haldol, when an allergy is really just a rash or just anaphylaxis, where you have a lot of swelling, cardioedema, and you have trouble breathing. That's very dangerous, and those are allergic reactions. But neuroleptic malignant syndrome is not an allergic reaction. So we've had to redo a lot of people's allergies list to see what was going on, because now we know that if somebody was taking, let's say, Haldol, 10 milligrams, and they had neuroleptic malignant syndrome, they were medically treated and, of course, taken off the Haldol for a couple, 3 days. And now we know, as a result of very robust research, the person can go right back on Haldol, and it's not going to cause another neuroleptic malignant syndrome episode. So there's still a lot we don't know about NMS, but we do know that, and we do know it's not an allergy. Other side effects of psychiatric medications are sexual dysfunction, sleep disturbances, which can be a problem because the person can have a sleep disturbance from their psychiatric illness, and then weight gain. Weight gain, unfortunately, for psychiatric medications usually goes around the waist, and that is the only place that is very physiologically dangerous. You can have a nice big barrel chest and great big arms and a big thighs, not a problem. If you put your weight any place than around your waist, your back might not appreciate it, but it's really not much of a health risk. But if you have your weight around the middle, that's when you're at serious risk for cardiac problems, for diabetes, hypertension, hypercholesterolemia. It's a huge problem. A friend of mine who's an endocrinologist said that she can almost diagnose a new patient walking through the door if the belly walks in before the rest of the person, because that's where the weight is. If your BMI is over a certain amount, I think it's over 25, that's a problem. There are criteria for what your waist should be if you are not at risk. It's different for males than for females. There's something called metabolic syndrome, where the person will have high blood pressure, high cholesterol, diabetes, and a problem with obesity. And those four things really make up a metabolic syndrome that really challenges that person's metabolism. And we're talking just from psychiatric medications. You add something like an intellectual disability where people have propensities to put on weight around their middles, and their other medications that they're taking for their physical problems may also put the medication weight around the middle. So weight gain is a huge problem, and we're always trying to stay on top of it. There's a side effect called QT prolongation or QTC prolongation, and that's basically how long it takes the heart to go through its bump, its lub-dub. It's from the Q wave, QRST. Those are the waves that you read on an EKG machine. And if that gets spread out too far, it can cause some heart arrhythmias, which can lead to some major health problems. Most antipsychotics cause a prolongation, a stretching out of the QT complex, but Mellaril is the most problematic. It'll stretch it out very far, and that's why we tend not to give Mellaril very often, because it is a problem for cardiac problems. And that is not counting people who have, for example, Syndrome X, who have mitral valve prolapse or cardiac problems on their own. So things that help people improve and recover from schizophrenia are intensive case management, where the person really needs to have some help. And that's just with the schizophrenia. That's not necessarily adding the intellectual disability on top. But you do need to have this intensive case management. So let me talk about that for a few minutes. We are dealing with a very special population of people who have intellectual disabilities, and they more than likely have more than one physical problem. They might have a seizure disorder, they might have cerebral palsy, and they're more than likely to have a psychiatric problem. It might be intermittent, like depression. They might have a depressive episode and they get treated for it and they do very well for a significant period of time, but then they have a recurrent episode of depression. And when you have somebody with an intellectual disability who has any kind of a problem like schizophrenia, you have to keep in mind that they can also get depressed. Anybody with any problem can also have a layering of depression on them. So the intensive case management is very important because it helps the individual be tracked by people who know them very well. So they'll know if their symptoms of schizophrenia are a little out of control. Sometimes when people have higher levels of stress, their symptoms get worse. Their hallucinations worsen or their delusions worsen. And if it's a very pungent stressor, they might even change their symptoms. They might have always been delusional in a certain regard, and everybody's been able to manage that delusion. But then there's been some major stressor that came along, and now they're delusional in a completely different way, and they're hallucinating. So the intensive case manager, or if you don't have somebody with that specific title, somebody who knows that individual very well would be able to track the changes that are going on with the symptomatology. So that's an important feature of the intensive case management, to not only pay attention to the schizophrenia specifically, but also to be on guard for a depressive episode that can happen as well, or if the person is drinking or drugging. It's a much more recognized problem with people who have intellectual disabilities than it has been in previous years. We know that people who have ID are frequently drinking and frequently drugging, and it makes everything worse. No antipsychotic medication will be effective with any amount of alcohol in the person. The research has shown that it's mostly antipsychotic medication that doesn't work, but just by logic, an antidepressant will not work either if you are drinking alcohol, because alcohol is a depressant. And that's a practical issue about how somebody is coping with their illnesses or with their social situation. If they're coping by drinking, if they're depressed and they want to feel better, some people think that alcohol will actually elevate their mood. They've had a stressful day and they want a well-deserved drink of some kind. But actually alcohol is a depressant, and it will make the person more psychologically depressed, but it also is a physical depressant in a number of ways, and I think we get through that in another workshop. So the case manager is also able to detect if the individual is using. Are they drinking? Are they drugging? Are there symptoms of schizophrenia getting worse? Do they also have a depression layered on top of it? So that's where the person who is spending the most time with that individual is able to perform observations that are priceless in managing the illnesses and maintaining a healthy quality of life. Also, you need intensive case management because somebody who has a developmental disability and schizophrenia needs a lot of doctor's appointments. They need to go see the people who are prescribing for them. They need to go see their therapist. They need to work with their occupational therapist. They probably need physical therapy to a certain extent. And a case manager is going to be able to organize all of that and make sure people get where they are supposed to be going. So that's a lot that I put into that one little bullet of intensive case management, but it is an extraordinarily important feature. If somebody wants to recover from schizophrenia, that will improve the odds greatly. Atypical antipsychotic drugs, these are the medications that were put on the market in the United States following 1990 and forward. The first one was clozapine. That's the generic name. The trade name is Clozaril. Especially the use of Clozaril in people who use high hospitalization. They're in that emergency department or they're in a psychiatric hospitalization situation more than twice a year or more than once a year, I'd say. If they can physically manage it, then that would be the drug of choice. But atypical antipsychotic medications are very useful for people who have schizophrenia because it not only helps them with their positive symptoms, the positive symptoms being if you have that symptom, you're sick. It's not positive. Yay, you have this symptom. It's not positive in that regard. It's the positive symptoms are psychosis, so there's some break with reality. They're either hallucinating in one of the five senses. Hearing is the most common hallucination, and the most common thing that the person hears is not a voice. So if you say to somebody who has auditory hallucinations, are you hearing voices? And they say no, you've just missed the opportunity to assess what's really going on with them. Are you hearing something that I might not be hearing? Or if you know the person very well, are you hearing a lion roar? Are you hearing crickets in the room? Are you hearing telephones ringing? Those are much more common auditory hallucinations. Visual hallucinations, seeing things that are not there. And this also excludes illusions. Illusions are mistakes that we make in perceiving our environment, and everybody does it, and it has absolutely nothing to do with a psychiatric disability. So in the dead of winter in Nome, Alaska, if I glance out the window at the palm trees that are growing there, I know that when I look back that they're really evergreen trees. They're firs and they're blue spruces, that I had the illusion of a palm tree when I first looked at it. It was a mistake in how I was processing my information, and the mistake was quickly corrected. That's an illusion. A visual hallucination is where you see something that just isn't there. So you'd be seeing a palm tree in a bathroom where there's no plants at all. There's just blank walls and you're seeing a palm tree. That's a visual hallucination. Then the olfactory, smelling something, gustatory, tasting something, and tactile, feeling something, hallucinations. Those last three are much less common and usually caused by infections or maybe a cyst or a mass laying on a cranial nerve. But the most common ones are auditory hallucinations, followed very far as a second by visual hallucinations. So clozapine and all of the atypical antipsychotic drugs, Risperdal, Zyprexa, Seroquel, Geodon, Abilify, Fanapt, Safris, these are all of the Latuda, these are all atypical antipsychotic drugs. And they are also wonderful in helping people recover from schizophrenia because in addition to addressing the positive symptoms of schizophrenia, they also address the negative symptoms. Negative symptoms are things that are not there, that should be there if you were normal, if you were healthy. So, for example, one of the negative symptoms is alogia. A means it's not there, and logia is the use of language to describe your experiences. So alogia is this person is not talking a lot. It's also called poverty of speech. So you ask them, you know, how'd your day go? Fine. Kind of like talking to a teenager, but with pathology attached to it. They don't have a lot of words. And then there's another negative symptom called amotivational syndrome. So A, it's not there. Motivation, they don't have any motivation. Or avolition. A, it's not there, and volition is voluntary activity. So they don't have ambition or motivation, and they aren't moving and doing what people would normally move and do. And it's not due to spasticity, and it's not due to any other physical problem. So the negative symptoms are things that are missing out of that person's experience of life. And the atypical antipsychotic medications will address those negative symptoms. It might take 2 years to start to see a difference, but the older conventional antipsychotics don't do anything for the negative symptoms. As a matter of fact, they make them a little worse. Rehabilitation therapy. Oh, let me harken back to the atypical antipsychotic drugs. A lot of very competent research has shown that taking the medication on a regular basis without drinking or drugging is the best neuroprotective situation to be in. And they have a lot of very robust outcomes that show that people who routinely take their medications early on after they're diagnosed can go down to very low doses or maybe even off their antipsychotic medication when they are in middle age. Mostly because schizophrenia usually attacks old, young adults and adolescents to a certain extent. So if you get them on medication fairly early, then you can protect that brain from any degradation, and they'll be able to stabilize more easily. Of course, if you drink and drug on top of that, that's going to interfere with the effectiveness of these medications. Rehabilitation therapy or habilitation therapy, teaching people how to enjoy their leisure time, how to feel accomplished and like they're contributing something, how to keep them active and intellectually stimulated, how to give them something to learn, something to work towards, and also a way to teach others. The adult research, regardless of the intellectual capacity, shows that when you learn something, if you don't use it on a regular basis, you will lose it. So use it or lose it. There's actually a good reason for that phrase. But the best way to keep something is to turn around and teach it to somebody else. When you teach somebody how to do something, you learn it better yourself. So rehabilitation therapy needs to accommodate the peer experience so that the individual who is being treated is offering some kind of information or help or contact or support to somebody else with a similar problem. Family treatment is pretty important, although my definition of family and the research definition of family is very open. Family is anybody who cares about that individual. It can be a landlady, it can be the staff at the residence, it can be neighbors, it can be blood relatives, it can be adopted relatives, it can be just people who've been friends for many years. That's a family, the people who care about what happens to you. And what the recent research shows is that people recover from major mental illnesses like schizophrenia better when somebody cares about their life. Not that somebody's jumping in and solving all their problems and addressing something so that they don't have any negative experiences whatsoever. That's not the effort. The effort needs to be put into communicating that you care about that individual and what their experience of life is. And across the board, That's what people say helped them the most, is that somebody cared about them. They didn't have to problem solve. They didn't have to buy them things. They didn't have to take them to the dollar store every Tuesday. They just had to care. Social skills training is always important. I mean, everybody could use a little buffing up on their social skills, but especially people who have Asperger's or autism. Social skills are going to be a very big challenge, and people who have schizophrenia on top of that kind of developmental disability are going to be extra challenged because their thinking is very different, their logic is very different, and how you interact with people are going to be different challenges. So social skills training is pretty important in managing somebody who wants to recover from schizophrenia, whether they have an intellectual disability or not. So I imaginatively enough called this next slide the break slide. So let's take a break.